Hello, my name is Jim Sapersky. I'm the Chief Executive Officer of nView Health and the host of Mental Health Today. Today, we're delighted to have Dr. Tom Young. Tom is a co-founder and Chief Medical Officer for nView Health and has spent many years in the mental health area. But what I'd like to do is maybe, Tom, if you could give a minute and tell us a little bit about yourself, and thanks for being on the show today.
Thank you, Jim. It's a real pleasure to be on with you and to talk a little bit about behavioral health today. My background, I was a primary care doctor for many, many years, had the opportunity to be a teacher in family practice as part of my journey. In the latter part of my journey, I became extremely interested and entranced by the ability to provide behavioral health care in the primary care space. So over the last 20 years of my practice life, I've been in that behavioral health space. Founding nView was a way to bring really highly sophisticated tools to primary care doctors.
Wonderful. Thank you. Well, look, Tom, really some questions that I think the audience would like to hear about today. By virtually any measure, from everything I've read, mental health is in a state of crisis and has been in our country long before COVID-19. Based upon all the time and years you spend in it and the work that you do in it, because I know you work at the collegiate level as well as the work you do within the company, can you tell us a little bit about what's your perception and what's going on, and give us kind of your state of the union as it comes to mental health in America today?
Well, I can certainly give you my opinions of that. I have been fortunate enough to work in many venues over the years. I think one of the things that I would continue to focus on, both in the past and current and moving forward, is that the backstop for mental health in this country for many, many, many years has been the primary care providers. Those are nurse practitioners, pediatricians, internists, PAs, psychologists, others who are providing that primary entrance into the behavioral health world by both children and adults. We have had a crisis in this country in behavioral health for as long as I've been in healthcare. The stigma of behavioral health or mental health issues has gone from institutional based back to outpatient based. It is waxed and waned in its ability to serve the American public in varied ways. So I think the real issue here for us to talk about is not so much where it was, as it's always evolving, but we still have today in this country access issues, ability of people to get to the right kind of care, access to medication issues. So fundamentally, while we've progressed, we've not progressed at the same rate as we have in the rest of healthcare.
So, Tom, that's interesting. If primary care is the backstop, as you say, why is that a problem? Aren't all physicians trained at some level in psychiatry, psychology, medically trained? I know when I'm sick, my first thing is I need to go see my doc. So, why is that a problem? Are they not, are there problems with that, and what can be done to remedy them?
Well, I think that's a great question, Jim. I think there are a couple of problems with that, and that is more and more primary care providers are called upon to see more and more patients. The time being spent with patients has gone down, not so much at the behest of the doctor, but at the behest of the system. More needs, more people showing up. We're understanding that more and more of chronic medical conditions are affected by behavioral health. But the opportunity for a doctor to say, tell me really how you're feeling, and spend the time that it takes to understand that. And then again, as you point out, based upon experience, based upon training, psychiatry has become more sophisticated. Treatments in psychiatry have become more sophisticated. And to some extent, it's tough for primary care providers to keep up with all the changes. It's tough to know how to diagnose all the sophisticated, complex behavioral health disorders that we see today. It's difficult to keep up with all the medications that are available in the behavioral health care space or in the psychiatry space. So it's just not something that can be done quickly. It's not something that can be done easily. And for the most part, tools don't exist for primary care providers beyond some very simple tools to do the diagnostics. You can't order an x-ray of somebody's emotions. So we don't have, to some extent, tools out in the general public for primary care providers to use to get those sophisticated diagnoses.
Interesting, interesting. That sounds a bit like a perfect storm when it comes to dealing with mental health. We've got surges in caseloads. We've got not enough people trained to deal with it. So tell me a little bit about the screens and why that's important, and are they being used today? Do people use screens very often today? And so if you could spend a minute just telling me a little bit, how are things being done today? Because it doesn't seem like it's working.
Well, I think it's working as best we can make it right now. Screening for behavioral health disorders, mental health disorders, really has become much more commonplace than it was, say, in the late 1990s. U.S. Public Health Service Task Force on Preventative Services has long supported the concept that screening for behavioral health is important. The American Academy of Family Physicians, the American Academy of Pediatrics, all have encouraged primary care providers in those specialties to do screening for adults, for children, particularly children 12 and up should be screened annually, for example, under the U.S. Public Health Service Task Force. But unfortunately, to some extent, there have been limits to the ability to get screening done. The multitude of EHRs that are out there all have different protocols built in. Some of the tools that are currently out there, while they have been around for a while, really don't provide the quality of screening that we need to be able to do this right. So people do screen. That's not to say they don't. It's to say that there's not enough of it, and there's probably not enough sophisticated screening beyond sort of general topics in behavioral health that really needs to be done. And we also need to focus a bit more on children. Children need to be screened for depression and anxiety, not just adolescents, not just adults. So more and more we're understanding, kind of one of the old rules when I was in training many years ago was, doctor, 50% of the people that come to see you won't really be sick. And what they meant by that is that 50% of the people that walk in a primary care doctor's office often have much more than just the disease they bring with them. They have the emotional and historical baggage, if you will, that comes with them. And as it enters the room with them, unless I ask about it, I'm not likely to hear about it. And if I don't know how to ask about it, and it's not part and parcel of my process, I'm not likely to find it. So I think screening becomes sort of the entryway into a person's emotional status, if you will. So screening becomes doctors' easiest tool, and giving doctors tools that can be used with children, can be used with adults, used with people like me, senior citizens, if you will, that can elicit the right piece of information. Good things happen between the physician and the patient when that type of encounter occurs. It's more meaningful, and it provides a bit more opportunity to really improve the health of that patient.
When I think about screening, though, and I think about people coming into the physician's office, a couple of questions come to mind. Is one, what age should I be screening? Two, how do I know that the screens themselves are accurate? How does that supported? Because claims are easy things to make. And then what's the frequency?
To take those kind of a piece at a time, I think one of the things is kind of the theory: screen everyone.
Okay.
It never hurts to ask. Okay, I think that's really sort of the mantra here with screening. Screen everyone. Children.
Can I steal that tagline from you, Tom? It never hurts to ask.
Yeah, absolutely. And so I think the other part is screeners can be validated in multiple ways. Many of them are available by virtue of involving yourself, National Institutes of Mental Health, Some of the other screening tools are validated in other formats as well. So validated screeners are available. You can find them in many areas, specific areas, for example. But I think, you're talking about if I'm screening for a set of symptoms, that's one thing. If I'm screening for diagnostic groups, that's one thing. So you need to select the tool that's going to give you the most information in the most expeditious way that is valid. And so I think all ages need to be screened. People often say, well, 6-year-olds maybe not. No, 6-year-olds do get depressed. 6-year-olds do get anxious. And so from that standpoint, screen everyone, screen them often. There's no harm in asking at any point in time. So if you may not see something at an annual physical, but 6 months later, a patient may come in and you may need to just ask that question again. Here's a screener. Let's go through that again. So I think there's no specific answer, but at least at minimum, once a year, sooner if need be.
Very good, very good. So we start early, we screen often. And on the question, is it the same group of questions for a screen that would be for an adult, or are they age appropriate? How does that work?
Yeah, they should be age appropriate, obviously. You need to have the wording in there that children can understand. You need to have wording in there that perhaps the parent can assist the child with the response, particularly at the younger ages, probably 6 to 12. That's where a parent and a child together can begin to look at the questions. The parent may give a lot of the feedback. But beyond 12, a lot of children, you can ask them questions. In many states, they are protected at age 14 for controlling their own mental health questions and answers and responses and treatment. So depending upon the state and how that works and the parents, certainly age 12 and up can answer most screeners that are age appropriate.
Excellent. Well, let me change topics for a minute because I really like to jump to something related to 2020. I mean, this has been a year of unprecedented challenges across the globe on so many scales and irreconcilable loss for lots and lots of people. So tell me, a system that by all measures we think was in crisis well before the pandemic, what do you think the impact of this pandemic has had on the mental health care, not just in the US, but on a global scale?
Well, like many people, I think we're clearly understanding that this has had significant effect on all of us around the world at all ages. And by all ages, I mean well below 6, younger children, regression in their behaviors, all kinds of activity that we've never seen before in this volume, in this consistency. So the pandemic has created not only problems in anxiety and depression, but it has certainly triggered worsening of most mental health conditions. There's data out there now that says COVID-19 itself may cause some behavioral health problems as a result of the infection. One of the things that we're seeing, particularly in the athletic spaces, emotionally, is that kiddos who get COVID in athletic spaces, we're now looking at things called brain fog as a result of this. They're emotionally spent, they're depressed, they're anxious, their cognitive skills, their ability to think is impaired. So COVID is a strange actor. So it's not just because we're locked up, because the world has changed, because we can't go play. All that's all extremely important. But there's also the part that we need to look at that says this virus may be affecting the brain in a lot of neurophysiologic ways that we're not clear about yet. But clearly, when you look at today, the number of people in my world, in my practice world, the amount of anxiety and stress in collegiate folks is unprecedented. I mean, I've never seen it this way in terms of the depth of despair, if you will. So you start talking about things other than depression, you start talking about things like despair. You see enormous spikes in populations with suicide. So there's a significant effect that COVID has had from all aspects, whether that's the portion that we would expect. If you tell me I can't go out, I can't go see my grandparents, I can't do this, I can't do that. And thinking for an instant, I think about my grandchildren, trying to keep a 9-year-old in front of a screen for 8 hours a day. Good luck with that. We turn parents into educators. Good luck with that. I mean, it's all sort of compounded itself at this point.
Kind of related to that, what we read about a lot and hear a lot about in the news today is the impact all of this has had, a pandemic, not just on the normal average middle person like myself that may end up as a patient, but as a first responders and physicians, people dealing with this daily. And as someone who still practices and still works directly, both at the collegiate level and in substance use clinics, can you tell a little bit about the impact that you've seen on first responders, on our providers, the people that are really trying to help us deal with this?
Well, that's a great question, because a couple of things about that, Jim. In the substance abuse world, a staggering increase in substance abuse problems, staggering increase in number of opioid deaths over the past 12 months. So we're seeing an increasing pressure on systems, and when I say systems in healthcare are people. Mm-hmm. Whether those are ER docs, nurses, medical assistants, people in nursing homes, people in the substance abuse clinic because they can't get enough people into the units. The system hasn't been designed and isn't brisk and reflexive enough to be able to say, okay, your facility's been approved for 10 people, but the system, the community needs 40. Mm-hmm. But we don't have the response built in to allow sort of increased numbers in the need. So the pandemic creates need, but systems can't respond fast enough to support that need. And fundamentally what that does is it takes a toll. People in the healthcare space, no matter how hard they try, do become somewhat connected to the people that they care for. And if you listen to the words of physicians, you listen to the needs of nurses, it's tremendous struggle, tremendous guilt to some extent because I can't help them. Creative ways to let somebody die and even talk to their family. It takes a toll. And the other toll that's happening is tremendous numbers of primary care practices are closing their doors. They can't stay open. People aren't coming in. They're not getting the care that they need for other diseases. Their staffs are decimated by infection, simply because the vaccines really that we're seeing now may help that. But to some extent, we've lost practitioners. Many people my age, and even younger, in their 60s, have simply retired. I'm not going to practice anymore. This pandemic is too much. It's too risky. I can't do this anymore. So we've seen a real diminution in the number of primary care practices, the number of people to support sort of the infrastructure of our healthcare system. And so it's beyond just the emotional devastation. It's the devastation of the system that we're seeing at all levels, not just primary care, but just across the board. So we have to look at COVID in 2020 as a real turning point for us. Behavioral health is going to continue to be a problem. We're going to continue to see skyrocketing suicide, substance use disorders. This is not going to stop the minute the vaccine comes. Okay, the vaccine is not going to cure the mental health system that we have seen challenged by this pandemic.
Tom, that really brings up a couple interesting points to me. One, particularly if I think about 2020 and I think about the devastating effect it's had financially and economically on primary care, as you say, with people literally retiring or going out of business. And I think about all the people who have delayed going to see the doctors for all these elective procedures and the swarm of that post-vaccine, these people showing up, doesn't that add to the perfect storm? All of a sudden, people need to show up, and we are now man down in terms of physicians available to take care of them.
It absolutely does. I think it goes beyond the mental health crisis that we will see. It really speaks to the crisis that we will have, as you say, on the rebound. Okay, now I can get out. Now I can go have my heart disease checked out. Now I can go find out if I have hypertension. But maybe I've had hypertension and poor kidney function for the past year and a half. So I'm down the tubes, so to speak. So I think the reality is, yes, that's going to create an extreme continued burden beyond the time that we see the vaccine giving us sort of the freedom to get out. And the thing I would say is that this is not unique to the US. This is occurring worldwide. If you talk about Europe, if you talk about Australia, and in my world, I have an opportunity to talk to those people on fairly regular basis. It's the same everywhere. We're not unique in that. Canada, same exact problem in Canada. People are leaving the practice, so it will not end soon, nor will it end nicely. It's unfortunate but true.
So thinking about that, because I think when I go to my primary care physician, I mean, normally mental health screening, behavioral health is really not on their agenda. I go there, I get my physical, and I go away. And it sounds like, and factually, they are the people that are really having to deal with this consistently. What are some advantages, I mean, across the board for primary care physician, for instance, to really want to adopt behavioral health more into their practice or be more forthcoming about putting that as a part of their patient intake process per se?
Well, I think, behavioral health integration into primary care has been a topic of discussion for the past many years. Now, how to do that has always been sort of the secret sauce. How do you get that done? And it's different in different locations. It's different if you're, I think back to my very first practice days. I was a primary care doctor, and I was the only one for 1,000 square miles. It was 30 miles one way to a 12-bed hospital. It was 400 miles the other way to a multiplex hospital, if you will. And it's different there in that environment than it is in an urban group environment. But for physicians, the ability to understand that patient, even if you're not going to provide the care, your ability to understand what that patient needs and help them find it somewhere else. Because fundamentally, a lot of primary care physicians don't treat significant psychological and behavioral health disorders. Most primary care doctors, unless they're in areas where there's no one else, probably aren't treating patients with schizophrenia, probably aren't treating people with significant anxiety disorders, probably aren't treating people with significant OCD, because those disorders require a team, a group of people. So, but for the physician to understand what that patient needs and be able to offer that in some other environment, i.e. through referral, that's the key. In other words, in this country, finding the disorder and then figuring out, based upon your environment, your location, and what's available to you, what's the best thing is really the key step.
Got it. Another question is related to that, too, is as a physician, as a provider in one that may be struggling, is there financial incentive, or I assume, are any of these screens and tools available? Are they reimbursable? Do they have potential billing codes? Is there a potential revenue opportunity for these primary care physicians in adopting some of these behavioral health measures or not?
Certainly there are. Things are changing, and we have seen some code changes recently that, and the word that I always come up with is compensation. You can be compensated for the time. Now, screeners have specific codes. Uh, we as physicians operate under a system that says E&M, evaluation and management codes, and there are evaluation and management codes for doing more in-depth psychiatric interviews in your practice. So that there are codes for following patients, because one of the key elements in the success model, particularly as we move out of COVID and back into the world of figuring out our own system and move to value-based care, the ability to demonstrate improvement. So following and tracking, all of these have compensation attached to them through reimbursable codes. Depends upon the system that you're in. For example, are you in a managed care program? Are you in a Medicare Advantage program? Are you in a Medicaid managed care? Each program, each payment system is a little bit different, but for the most part, the systems have recognized that you have to provide some compensation to be able to get some of these things done and get them into the process of care. So the answer to that is yes. The answer is that it's a little bit different depending upon your payment system, a little bit different upon your payer. So that has to be, evaluated by every provider. But yes, on the whole, these are compensable codes.
So Tom, if I wanted to learn more as a provider or a physician out there, where would you direct me, or do you have any ideas about where people could look and find more information about what we've talked about today?
Well, there are a lot of sources at the federal government level through the U.S. Public Health Service Task Force on Preventive Services in terms of what's out there, what's available, what they look at. They are changing. They are looking at new things on a continuous basis. National Institutes of Mental Health has information, NAMI. There are several organizations. We at nView have on our website some information about tools, about opportunities, about things that you can learn. That's at nviewhealth.com or nview.com. And I think there's adequate opportunity through a lot of state-based programs. I know here in my state, we have a continuing education program where there's information, for example, on opioid abuse. There's information on mental health disorders available through the educational programs within states. There's CME programs that are available. Certainly nobody's traveling, so we're not going to conventions or studies or any of that sort of thing. It's all available by Zoom. So a lot of places to find it, but certainly, based upon this, if someone has questions, I'm always more than happy to have you reach out to me through nview.com, and we can kind of go from there.
That's great. Well, first of all, as always, Tom, it's always such a pleasure talking to you, and I always learn something every time I do. I want to thank you for being on our show today. We really appreciate your involvement, all the good work that you do on a day in, day out basis. I want to thank you all for listening to Mental Health Today. I'm your host, Jim Sapersky, and on behalf of our studio team, thanks for tuning in. Stay safe out there and take good care of yourselves and others.